Okay, I think we're ready to begin, and I'd like to ask you all to silence your phones, please, so we won't have any interruptions. My name is Judy Rumler, and I am a founder of the Steve Rumler Hope Network, and I'm chair of the Fed Up Coalition to End the Opioid Epidemic. The Fed Up Coalition was founded in 2012 and is made up of organizations from across the country that are focused on getting federal action to end the opioid epidemic. Many of us had worked successfully for change in our states and local communities and came to realize that we would have a louder voice in Washington, D.C. if we worked together. While there are now many other advocacy groups working on the addiction crisis, Fed Up is unique in its focus on the federal government, on holding the FDA accountable, and on working to reduce the influence of pharma. We take no money from the pharmaceutical industry, which makes it possible for us to objectively work to end the root cause of this epidemic, the overprescribing of opioids. Since I began my advocacy work, the number of overdose deaths due to opioids has increased from about 15,000 per year to over 33,000. There is so much more to do, to be done, and I hope you will join us tonight at our 7 p.m. vigil at the Ellipse on International Overdose Awareness Day. And then I hope you will march with us to the White House to demand action from the current administration. Absolutely. You'll be there? Yeah. All right. Oh, I love that response. Good. In the meantime, the Fed Up Coalition is honored to sponsor this press conference today and to join with other organizations in signing a citizen petition to the FDA asking for changes that would have a great impact on the opioid prescribing practices and save many lives. Press packets have been distributed to members of the press in attendance here today, and there is an electronic version of the press packet available on this website. And the press conference can be viewed later on the feduprally.org website. We have representatives from the signing organizations and other important advocates with us today who will speak to the need for this action to be taken by the FDA to remove certain opioids from the market. First, we have my dear friend Andrew Kolodny, Dr. Andrew Kolodny, who is Executive Director of Physicians for Responsible Opioid Prescribing and Co-Director of Opioid Policy Research at Brandeis University. We have Michael Botticelli, Executive Director of the Graken Center for Addiction Medicine at Boston Medical Center and former Director of the Office of National Drug Control Policy, who worked tirelessly for our cause in that role. We have Dr. Jay Butler, who is President of the Association of State and Territorial Health Officials and Director of Public Health at the Alaska Department of Health. We have Dr. Howard Taft, Deputy Secretary of the Maryland Department of Health and Mental Hygiene. We have Dr. Caleb Alexander, who is Co-Director of the Center for Drug Safety and Effectiveness at Johns Hopkins Bloomberg School of Public Health, and Gary Mendel, founder of CEO of Shatterproof. So I'm going to now turn things over to Dr. Andrew Kolodny.
Thank you, Judy. And actually, there are quite a few people to thank who put a lot of work into organizing today's press conference and the evening events. Judy Rumler, April Rivero, Scarlett Gleason are all people who worked very hard on this event you're attending today. I'd also like to thank Emily Walden from Fed Up. Emily is not here with us today. She's at the Kentucky Fed Up rally. Emily has organized rallies across the country. So in more than 30 states, there are Fed Up rallies today. And these are rallies organized by groups that are doing terrific work on a local level. The reason that they are rallying today, International Overdose Awareness Day, many of them at their state capitals and in front of federal buildings, The reason that they're rallying is to call on the federal government to do its part in tackling the opioid crisis. There are county task forces around the country, state governments, community coalitions, all doing everything they can to tackle the problem, and it's not working. As we all know, the epidemic is still getting worse, and it is time now for the federal government to help. At the rallies across the country, there will be fed-up requests for Congress to appropriate $60 billion over the next 10 years. That's $6 billion a year for 10 years, so that in every county in the country, somebody who is opioid addicted can access effective treatment regardless of their ability to pay for it, so that they can access effective treatment more easily than they can access pills, heroin, or fentanyl. The other thing that people at the Fed Up rallies will be requesting or supporting across the country today is an announcement that I'm about to make, which is a request to the Food and Drug Administration to remove ultra-high dosage unit opioids from the market. Ultra-high dosage unit opioids are opioids that, when taken exactly as directed, the patient is on a very dangerous dose of the medication. To give you an example of an ultra-high dosage opioid, OxyContin 80 milligram tablets. That one tablet is equivalent to 24 Vicodin in a single pill. Exalgo, 32 milligrams, that's a hydromorphone pill, the same ingredient in Dilaudid. That 32 milligram pill has the equivalent of 25 Vicodin in it. The Subsys fentanyl spray, it's a spray that goes under the tongue. The 1,600 microgram dose of that spray has the equivalent of 57 tablets of Vicodin in one dose of the drug. These are not medicines, these are lethal weapons that should be removed from the market. The request to FDA in the form of a citizen petition is coming from the Association of State Territorial Health Officials. That's the organization representing health commissioners and health secretaries from states across the country. The request is coming from Physicians for Responsible Opioid Prescribing, the National Safety Council, the American College of Medical Toxicology, that's the poison control specialists from around the country. The request is also coming from Fed Up, and it's coming from Shatterproof, and you'll be hearing from people representing these organizations today. The request to FDA comes on the heels of a report that was just released last month from the National Academy of Sciences, which urged FDA to overhaul its opioid policies. It urged FDA to consider misuse when weighing the risks versus benefits and deciding which products to approve and which products to remove. The commissioner of FDA, Dr. Scott Gottlieb, has enthusiastically embraced the report from the National Academy of Sciences, which is why we are hopeful he will act positively on the request that we're making. Factoring in misuse into decisions about what drugs to remove is very important. In 2015, an estimated 11 million Americans misused a prescription opioid, and the most common reason, more than 60%, were borrowing a pill to treat their own pain. It was misused to treat pain. Now, borrowing people's medicines is an unsafe thing to do. But when you borrow an ultra-high dosage unit opioid, if you're someone who is not used to taking an opioid, borrowing that one pill can lead to a fatal overdose. A teenager curious about experimenting with an opioid who makes the mistake of experimenting with just one ultra-high dosage opioid can lose her life. And that's exactly what happened to Pete Jackson's daughter, Emily, who lost her life at the age of 18 years old. She wasn't addicted. She was experiencing an opioid for one of the first times, took an ultra-high dosage OxyContin at a party the night before starting college, and fell asleep at the party and never woke up. And so we have to have these products removed from the market. So I don't want to keep talking. There's going to be an opportunity to answer questions. Hopefully we have some press here as well, and we'll answer questions from reporters. I'd like to now introduce Michael Botticelli is our former drug czar, and he is someone who worked very hard to champion the opioid issue when he was in the Obama administration. He was a strong supporter of FedUp, and he played an important role in the little bit of money we finally did see from the federal government, which is the $500 million that we're going to see this year and $500 million next year. Michael Botticelli played a very important role in our obtaining that funding. So let's welcome Michael Botticelli.
Good afternoon, everybody. It's really my honor to be here today, and I want to thank Judy and Andrew for your unending advocacy and leadership and friendship and the work that we were able to do together, as well as the rest of the folks on the panel here today whose work I've come to appreciate and admire. And I also want to acknowledge the fact that I didn't do this work alone, and I have some federal colleagues here, Tom Coderre from SAMHSA, who is another strong person in recovery who's doing this work, and my good friend Dave Noble. I actually probably would have not gotten the job had it not been for Dave Noble, who vigorously pursued my nomination and confirmation as a gay man in recovery. So thank you, Dave, for that opportunity. So we are now well into the second decade of this epidemic. And while we have seen this evolve and change over time, one thing has remained tragically clear: the unimaginable pain and suffering that is left in its wake. During my time at both the state and national level, there are two ingredients that we must see, that we must demand from our federal officials: leadership and resources. While I'm very proud of the work that we did under the leadership of President Obama, we were under no illusion that our work was close to being over. We hoped that we built a strong foundation for the next administration to build on. And to say that I am heartbroken is putting it mildly. While we hear noises that this epidemic is a priority, actions prove otherwise. You cannot call this a national crisis and at the same time continue to call for dismantling the very mechanism by which the vast majority of Americans get access to life-saving treatment and comprehensive care. Some of the same people in Congress that I traveled this country with and heard the same stories voted for a bill that they knew would have tragic consequences. You cannot say that this is a priority and simultaneously cut hundreds of millions of dollars from the very federal agencies whose efforts are critical to this battle. While building a wall and helping drugs stay out of this country and out of our communities are important, this is not an epidemic that started by a drug cartel. This is an epidemic that started right here and still rages by the policies and practices in the United States. For a senior advisor in the White House to call this disease a matter of willpower, or for our Secretary of Health and Human Services to call medications just substituting one opioid for another, or that returning to overly cruel and harsh criminal penalties is ill-informed, not based on science or fact, and break promises made to the people in this room and in this nation. So what do we need from our federal officials? We need leadership and we need resources now. We need you to deal with this as a health issue, not as a moral issue or a criminal justice issue. Just about every law enforcement officer I talked to during my time said we can't arrest and incarcerate our way out of this problem. We need you to ensure that every American has access to a full continuum of services from prevention to treatment to recovery supports. We need you to ensure that people have access to high-quality, affordable health care, naloxone, and clean syringes. We need you to do everything in your power to mandate safer prescribing practices, disposal of medications, utilization of prescription drug monitoring programs. And I want to applaud the efforts of Prop and ASTO for calling for the removal of dangerous products from the market and for your steadfast and strong leadership on this issue over the years. I have often heard Dr. Nora Volkow, the head of the National Institute of Drug Abuse, say that we know what works. We know what to do, but do we have the will to do it? Just last week in my home state of Massachusetts, we finally had some good news. That after year upon year of increases in overdose deaths, the first half of 2016 showed significant reductions from the previous year. No one is breathing a sigh of relief. No one is congratulating each other. But it does show us that we can make progress if it's a priority and if we have the leadership and we have the resources to do what we know to be effective. Today, we honor and remember those we have lost and give comfort and love to those who they have left behind. I will never forget the day during a legislative hearing in 2007 that Joanne Peterson and a group of parents from Learn to Cope unrolled a scroll with the names of the sons and the daughters, brothers and sisters, and husbands and wives that we have lost. It is in their names that we stand here today and demand action. Thank you.
Next, we're going to hear from Dr. Jay Butler, the Director of Public Health for the state of Alaska and the President of the Association of State and Territorial Health Officials.
Thank you, Andrew, and thank you, everyone, for being here today. It really is an honor, and it's so invigorating to see the passion and the knowledge in this room, that people understand, not only in their hearts, but also in their heads, what we need to do to address this terrible epidemic. At the state level, we are addressing this problem as comprehensively as we can. I ran into an old friend the other day, a colleague, and she said to me, so what's the answer to this opioid thing? And I thought for a moment, and I said, well, the answer is to first realize there is no the answer, that it requires a multi-pronged approach. It takes all of us. And I'm here very proud to speak for health officials across the states and the territories that we are trying to do a number of things. And I think of it in terms of sort of three prongs: addressing the harms that are the immediate threats to life, such as making clean needles and syringes available to reduce the risk of hepatitis C, HIV, to make naloxone available to reduce overdoses. We've been very active in our state with naloxone, but of course that's just a tourniquet. We also need definitive treatments. So second prong is addressing those issues related to how do we get people into treatment, making access to treatment available, and also removing the stigma, which is oftentimes one of the biggest barriers. And I just really have to give a shout out to Michael Botticelli, who's really helped us change the language we use when we're talking about addictions. And then the third prong is primary prevention, addressing some of the drivers that lead to use of drugs, including manipulating or influencing the environment that changes how there's access to drugs, whether they be illicit opioids or prescription opioids. And that's where the issue that we're here today for fits in. Because right now there's availability of drugs that, while we want to provide pain relief for the vast majority of people, they are dangerous. We know that high doses of opioids increases the risk of overdose. We also know that some of these very high, ultra-high dose units, that if they are taken, as we were hearing earlier, as part of maybe experimentation, or even if they're borrowed or loaned by a friend, the risk is significant. In Alaska, we're very accustomed to having a lot of outdoor equipment and sports for hunting and fishing, and we share that a lot. We've gone forward with a new campaign that not sharing is caring, because we know many people who start their route to addiction when there's an injury and they borrow a medication. And that borrowing is even more dangerous when we're talking about these high dose units. So there's so much we can do at the state level. The tip of the spear is really at the community level. And all of you represent the communities you come from. And we can do some things at the state level to make that happen, but we also need support from the federal government. And this takes a lot of different, there's a lot of opportunities that I believe are available, and maybe we can get into that some during the question and answer. But we're here today to point out one in particular. The FDA has embraced the concept of looking at drugs not only in terms of patient safety, but also the risk in the community. And we believe that these high-dose units are an opportunity to take something that is dangerous off the market and make our communities safer. So thank you, and I look forward to the question and answer period that will follow.
Next up is Howard Haft, the Deputy Secretary for Health for the state of Maryland.
Thank you very much. Good morning, everyone. Or is it afternoon now? Yes, thank you. I'm very honored to be here with this esteemed panel, and I come to you as a state health officer, but also as a parent and a member of a community. And in all of those aspects, I have been touched, as you all have been, by this horrific epidemic with 33 million and perhaps as high as 50 million people dying in our country in a year's time. I think we all have to acknowledge, recognize that this is something that needs immediate attention, that every minute wasted and anything that we can do to interrupt this epidemic is a minute where people are losing their lives. And that's why it's important for me, again, as a parent, as a health officer, and as a member of a community, to be here today to speak to you, to help encourage our federal government to do everything that they can do in this epidemic. There's no question in anyone's mind that prescribed opioids are at least part of the root cause of this epidemic, with 240 million prescriptions. That's not pills. That's 240 million prescriptions last year for opioids in a country that only has a little north of 300 million people. This is clearly something that's out of balance. And among those prescriptions are many prescriptions of these ultra-high dose medications that each one of them by themselves can be lethal. They can be lethal through misuse, as you've heard, or through misadventure. A child who happens to find a pill on the carpet and takes that pill and then dies within minutes or hours. Or someone who is opioid naive, who is not used to getting 240 morphine milliequivalents of opioid in one small pill. That is tragic, and that is preventable, and that is why we're here today, to do something about that. And there are, thank you, yes, we are here to do that. And there are credible other alternatives for those who are in pain and need these kinds of high-dose prescriptions. There is credible alternatives that can take these things off of the market and make it still safe and credible for everyone who's here. So we need to enforce the laws that are here. We need to be able to change the laws that we can change to make this a safer environment for everyone. There are really three legs, I think, to solving this problem. Part of it is prevention. Part of it is enforcement. And a very important part, as you all know, is treatment and recovery. So we focus on today with this is prevention. We want to prevent people from getting these very toxic medications when they have other alternatives in the marketplace. And particularly, we know that the higher the dose of opioid that an individual takes, for whatever reason, the more likely they are going to go on an inescapable march toward addiction. And once they've gone down that path, you all know how hard it is to get off of it. So for so many reasons, we're here today to join you in your efforts and to encourage our federal government to do everything they can do for prevention, for enforcement, and for treatment. So thank you very much.
Next up is Dr. Caleb Alexander. He is the co-director for the Johns Hopkins Bloomberg School of Public Health Center for Drug Safety and Effectiveness.
Great. Thank you, and thank you to the organizers, and thank you to all of you who are family members and have lost a loved one or have experienced the effects of opioid addiction. And your experiences and your stories is really what motivates a lot of the research that we do, that my team does at Johns Hopkins, and really is the underlying force that drives our commitment to try to improve the use of opioids in clinical practice, improve the risk-benefit balance of these products. So if you'll humor me, I'll just say a few words. I guess I'm here as the pointy-headed academic. I don't have any PowerPoints or anything. But I do want to just mention a little bit about why I think that this petition is an important one. And the first main point is that to a large degree, the injuries and deaths that we've seen from opioids are volume driven at a market level. In other words, if you plot the line of opioid sales over the past 20 years and superimpose the plots for deaths or injuries, they're essentially, you don't have to have a degree in biostatistics to see that they're highly correlated. And for 20 years, we've been watching this epidemic get worse, really hidden in plain sight. Now, it is true that all drugs have risks and benefits, and when I'm teaching about prescription drugs, I'll tell people, well, a drug isn't inherently good or bad. This is a pill. This is not an inherently good or bad pill any more than a hammer is inherently good or bad. And in fact, that's also the case with a prescription opioid, that for the right patient at the right time, of course, for patients at the end of life, or those with severe pain, prescription opioids can be invaluable. But as all of you know far too well, what we've seen in the past decade or two is a huge increase in their use for chronic non-cancer pain. And in these settings, the risk-benefit balance simply is often unfavorable. That is, that the risks outweigh the benefits of these products in many, many settings where they're still being all too commonly prescribed. If you imagine, just imagine if we had 20,000 people dying from oral contraceptives or thyroid replacement hormone or osteoporosis treatments or a new kidney cancer treatment. I mean, it's hard to fathom the degree of mobilization, and it's hard to even imagine that it would ever happen. And here we are with a product that is regulated and FDA approved and is on the market and is killing far, far too many people. Now, I think that the petition is important, and I think that there are many myths that I just want to briefly take on a few of them, because I think that these have delayed our ability to really turn the epidemic around. You've already heard it's a complex one. I agree with that. There's no magic bullets. I agree with that. But there are some myths that all too often we hear, and I think that these add confusion and ambiguity to efforts to reduce prescription opioids. So the first is that if you have legitimate pain, you won't get addicted. And in fact, I was taught that when I was a resident in internal medicine, and that just ain't true. Yet I was part of a whole profession, a whole generation of healthcare professionals that was taught essentially that if the patient had real pain, quote unquote, that the risk of addiction was overplayed and that one need not be concerned. A second is that addiction starts with abuse, that patients become addicted because they're abusing the products. And this, too, we know from many, many studies is not the case. That is, that many, many patients that ultimately develop addiction start with being treated for chronic pain. A third is, and probably the most important here, is that there's no way to reduce our reliance on opioids without hurting those in pain. And this just ain't true either. And it really presents a false dichotomy or a false dilemma where it seems like we have two bad options. Either we reduce prescription opioids or we improve the quality of care for the millions of Americans that have pain. And there's no conflict between these two. And so I think it's really important that this be emphasized and that we look at the science. And the science tells us that. The science tells us that, if anything, when you start peeling back opioids, for example, for people that are on extremely high doses, their pain doesn't get worse, it actually gets better, as does their physical and psychological functioning. The last two that I'll just briefly mention, and we can address them more during the Q&A if there's interest. So one is this focus on abuse deterrent formulations and risk mitigation measures, things like urine toxicology, contracts, unscheduled pill counts, patient stratification, and the list goes on. And, you know, I guess what I'd say here is the short version is, if it looks too good to be true, it probably is. And there's lots more to say about abuse deterrent formulations, but I've been heartened that there's been increasing scrutiny of the ultimate contribution that these products will make. I'm not opposed to abuse deterrent formulations, but I think that that some have overinvested sort of what they actually can do in changing the shape of the epidemic. And the last one is the issue of heroin and fentanyl. And essentially, some have argued that there's sort of a zero-sum game, and if we reduce prescription opioid use, heroin and fentanyl deaths just increase. And it's not so simple, and it's not a zero-sum game, and there's no conflict between reducing our reliance on prescription opioids and tackling the very, very serious issues with heroin and fentanyl use. So thank you again for the opportunity to speak, and thank you, all of you, for sharing your own stories and for the work you're doing in your communities.
And finally, we're going to hear from Gary Mendel, a tireless advocate, the CEO and founder of Shatterproof.
Good afternoon, everyone. I too, as everyone else is, I'm truly, deeply honored to be here with all of you, and for all the work you all do every day. And I'm also, as I sat there and listened to my fellow speakers, panelists, and I was looking out at all of you, I couldn't help but notice the shirts with pictures of loved ones lost, pins of loved ones lost. And for that, with all of you, I share a common bond, and my deepest condolences, and I share your pain. So thank you for being here and for everything you do. The philosopher Victor Hugo once said, "Nothing is more powerful than an idea whose time has come." Did he mean that all ideas are powerful? I don't think so. Because all ideas that come forward that are great ones, powerful ones, many of them aren't embraced. Because it's all about timing. Those of you who, well, to back up, when I talk about timing, it's all about ideas coming forward at a time when our world is ready to accept them, to embrace them, to change the way they think about something. For those of you who know me, a few of you in this room, you know that I lost my son Brian related to opioid addiction back in 2011. But you also may know, for those of you who know me, as the months went on, I was further torn apart when I learned that there had been this body of knowledge funded by NIH research that's sitting in peer-reviewed medical journals that has proven without any doubt that there are programs we can put into our communities that will absolutely prevent the number of our children and our teens and our loved ones who ever become addicted. And there's also a body of knowledge sitting in our peer-reviewed medical journals, I learned, that can improve outcomes in treatment. so my son and so many sons and daughters, like so many of you sitting here, could have a better chance at treatment and a higher probability of living a happy and successful life. And I was just torn apart seeing all this stuff sitting in peer-reviewed medical journals, which I hadn't known about as a parent, that could have saved my son's life and hundreds of thousands of others if it had only been implemented. I guess the time wasn't right for these ideas. And I was also struck by the fact that for every disease in this country, every major disease, there was one well-funded national organization that was funding private research, advocating for change, working to ensure that the research was proven to work, was taken out of the peer-reviewed medical journals and implemented in our communities and our healthcare system, ending shame and stigma, and providing information, support, and hope for so many. And no such organization existed for addiction. And maybe the timing hadn't been right for that organization to be launched. But for me, the timing was right. In a few months after learning this, I left my career in business and formed our organization, Shatterproof, to create such an organization for addiction. And as I stand here now, a few years later, there's no question I miss my son desperately. However, in many respects, I feel blessed because I've had the opportunity to travel all across this country and meet so many wonderful people here on the panel today, many of you in the room today who have joined with us, and together, we've all joined together and saved countless lives. And that feels wonderful. But this tragic epidemic is taking us over. We're saving lives, but we're not catching up. And the ideas you heard from the panelists today are the same ideas that I'm going to list in a minute. It's ideas we've had for a while. They've been sitting in the peer-reviewed medical journals. But possibly, their time has come. Possibly these ideas will now turn into powerful ideas because their time has come. Today, as you heard, and I fully support, it is the right time, if not too late, but it's the right time right now for the FDA to take off the market all ultra-high-dose opioids, off the market completely. Because it's been proven time and again, and you've heard it up here from every panelist, there is no evidence that these pills help people, and a lot of evidence they're killing our loved ones. So there's no time like today. Today, the time is also right for the president to declare the opiate epidemic a national emergency today. And declaring, let's be clear, declaring it a national emergency is not going to change the issue, but it will provide more resources to the issue and a higher focus, and it should be done without delay. Number 3, it is the right time in this country for every American, as you've heard before me, every American who's afflicted with a substance use disorder, whether it's opiates or another substance, to be treated with love and with empathy, to be treated with protocols that are rooted in science, to be treated with recovery services that extend well beyond the initial treatment. All 3, just like we do with other diseases. Today, it is the time for every single prescriber in this country of opioids to follow with strict compliance the CDC guideline for prescribing opioids for chronic pain. Not some of the doctors, all of the doctors, starting today. And it is time, starting today, that naloxone is everywhere, carried by every first responder, and in every building where you see a fire extinguisher, there should be a naloxone kit right next to it, as pervasive as fire extinguishers. I often think of the last time that my son Brian came home for a visit. It was 4 months before he died. And that last day, we played golf in the morning, had a family barbecue in the afternoon, and that evening, the two of us were sitting on the back porch talking about his favorite topic, the Giants, Eli Manning. And then the conversation turned to his recovery. He looked at me and he said, "Dad, someday, I wish that people would realize I'm not a bad person. I just have a bad disease, and I am trying my absolute hardest." Well, that someday has been way too far off in the future. Because maybe the time wasn't right. It was a powerful idea, but the time wasn't right. But today, joining with all of you, all of us, the time is right to grant Brian's wish, and the wish of so many of you in here, all of you in here. Today's the day. Today is the day. Today is the day to now look at this disease for what it is, a disease no different than cancer, diabetes, or heart disease. And to treat people with this disease with love and respect, treatment based on science, and all the things that we would do for anyone with any other disease. Thank you so very much. Thank you.
Good afternoon. My name's Don Flattery, and we're going to try and take some questions from members of the press here present today. And through a site, I'm a little amazed that Judy and Andrew have asked the least hip person in the room to monitor a site called Hip Chat, but I'll do my very best. So we'll alternate questions from members of the press in the room, and we'll try and direct them to those who wish to answer, and then we'll alternate with any questions submitted online. We have two people with microphones in the room. Those microphones are on, Bill and Randy, and the gentleman monitoring the board will turn them up when you hand them. Please, if you have a question from the audience, wait for the microphone so that we don't repeat it. So, from the floor.
Hi there. Hello. Yes, wait. Hi there. I'm a British journalist. I've been covering this story in Pennsylvania recently, in northeastern Pennsylvania, and the tragic story of one family who lost their son. I have two questions, really. I don't know who would be best to answer this. The first question is, I'm just wondering whether the discussion is starting at the wrong point. You talk about high-dosage opiates, but in the case of this young man who died, he was given Vicodin when he broke his clavicle, his collarbone. And in the UK, for example, you would be given maybe paracetamol or ibuprofen. So already the dosage is incredibly high, let alone the high dosage, it seems. And that doesn't seem to be a discussion point at the moment. It's all about the high dosage opiates, but surely that opens the way for that. And secondly, is it not time for campaigners to start exposing the politicians who are working with Big Pharma to open the way? They seem to be opening the way for them to flood the market with these high dosage opiates. Is it not time to identify some of those politicians and question why they're doing that?
You made some very good points. Let me just first reiterate what we heard from Dr. Jay Butler, which is that there are no simple solutions to the opioid addiction epidemic, and we are under no delusion that removing ultra-high dosage unit opioids from the market will solve the problem. Not at all. Another important point that we didn't really make today is that the vast majority of opioid overdose deaths are occurring in people who are opioid addicted. And in many cases, the opioid addiction doesn't begin with an ultra-high dosage unit product. It begins with a drug like Vicodin. people ultimately wind up on very high doses. So the majority of the deaths occur in people who are addicted, but there are also a substantial number of people dying of opioid overdoses who were not addicted and died from an overdose because they took one of these very dangerous opioids. So I will say that you're calling out the role of the pharmaceutical industry and its influence on Congress is a concern that FedUp shares with you, and we're a group that's been raising alarms about this issue for a very long time. We are now hearing from the Food and Drug Administration that they are willing to overhaul their opioid policies, but what we haven't seen from Congress over the past 15 years, we have not seen Congress hold FDA accountable for its failure to regulate the companies making opioids. And our concern is that the reason Congress hasn't required FDA to do its job is because of pharmaceutical influence on Congress. So thank you for that question.
I just want to add something.
You think should be identifying who these politicians are, who are paving the way, who are receiving campaign funding from big pharma companies, and exposing that. You think that should be a tactic?
I think that's a very good idea, yes.
So I will also add, it's not just politicians. So at the center that I work at Boston Medical Center, one of our researchers just published a study a number of weeks ago showing the extent to which physicians accept payments from pharmaceutical companies for prescribing of opioids. So 1 in 12 physicians in the United States and 1 in 9 family physicians has accepted some medical payment, some payment from a pharmaceutical company as it relates to prescribing opioids. So it's not just the money that pharmaceutical companies generate to political campaigns, it's the influence that they have over physicians as it relates to prescribing practices. So, I think that we also have to really think about kind of the ethical concerns, not just with our political folks, but with our medical communities in terms of accepting payments from pharmaceutical companies that have influence over prescribing behaviors.
Four. My name is Jeff Doherty, and looking at the opposite end of the spectrum of what we're doing for people that can't afford insurance and longer-term treatment for people that are on Medicare and Medicaid. Seems like everywhere that we have, there's 2 to 3 months of waiting list for these people to get treatment. And 90 days of treatment is cute, but it doesn't always work. We need longer-term treatment, up to a year, and funding for the more beds. In California, we have such extreme losses right now. The kids are dying every day, and we're out on the streets trying to fight for these kids, but then we can't find them a bed. We need the treatment centers to step up and give scholarships. We need the other places to step up and give scholarships. We need Big Pharma to put up some money to pay for treatment for these individuals that don't have. Okay. Thank you.
So what I'm going to say I think is probably not very popular, but I'm going to say it anyway, which is that we're not going to solve the opioid addiction epidemic by putting millions of Americans in beds for months or for up to a year. That's not a feasible solution, and even long-term residential treatment for many people with opioid addiction doesn't work very well. The treatment that has the most evidence supporting it, the treatment most likely to save many lives, is a treatment that we do have waiting lists for, that we don't have adequate access to. And I'm talking about medication-assisted treatment with buprenorphine, also called Suboxone. We need much better access to that treatment. And when I say that I believe that if we did have better access to it, we'd see overdose deaths dropping in the United States, I'm not speculating. It's happened before. So I'm sorry that you don't feel that way, but that is what we really need much better access to.
Thank you.
Hello, everyone. Thank you, FedUp, for creating today's dialogue. As a native Washingtonian and the CEO of Memoirs of 2165, who has lived through the crack epidemic and when there wasn't any solutions at the time for the crack epidemic. And it's so good to see that more money and more funding is going into this epidemic. My question is to the panelists, what year did society become so addicted for the need to relieve pain? It's like, did this just happen after the crack epidemic? Did we learn anything from the crack epidemic? What is being done? What year did we become so addicted to finding pain pills?
I'd like to comment in response to that. And I don't think there was one year or one moment, but I think that there was a decade or more where physicians like myself, and this is a confession, were told and believed that pain was the fifth vital sign. It was important that we asked everyone we saw in our hospital or in our outpatient clinics whether they had pain, and if they had pain, that the important thing was to treat them with opioids, long-acting opioids, and the myths that Dr. Alexander pointed out were at those times not myths. The ones that he's disproved, they were truths. And those are the truths that we were led to believe by pharmacy companies, by direct-to-physician advertising, and also by direct-to-consumer advertising that suggested to the population that you had an obligation to tell your provider about your pain, and they were obliged to treat you with that. We were measured in our quality if we did not subscribe to that. If we did not prescribe adequate numbers of pain medications, then it was held against us financially, by reputation, and that was the beginning. We've come a long way since then. We understand now that that is absolutely not the truth, that pain is something that doesn't need to be addressed with opioids, that there are a whole host of other modalities and better ways to treat pain than opioids. But it was nearly a generation that was sold that bill of goods, and that's one of the reasons why we got into this predicament.
Yeah, I have a question. My son died 3 years ago, and since then I became a bereavement facilitator. And I get to speak to hundreds of different, actually literally over hundreds of parents now that have lost children due to opioid deaths. And I always ask them one question: how did your child start? When did they start with this? And 90% of the time I hear the same thing. My child went to the dentist and had his tooth out, had wisdom tooth out, and they gave him Percocets. You guys that keep talking about chronic pain, what is the deal with giving Percocets and Vicodins for people who get their fillings done? Come on, you know, I'm 70 years old. I've got 16 fillings. I never had any of those things, and I survived quite well. We had a thing called buffering, you know, and you know. So I mean that's one thing that I want to ask you a question, because it seems like it's not. It starts at the lower level. Then if they get into a car accident, the first thing they want to do is pump them with some sort of morphine or some sort of opioid right away, and now they don't even know their background. And that's one part of it. And the other question I have is that, are they still being judged by the government? I'm trying to remember the name of the company, but it's like a program where they get judged, and they could, if they're not satisfying this fifth pain, you know, this fifth vital sign of pain. And
so, I think you're raising really good points. And on your first point about treatment of acute pain and the example you gave of dentists giving out opioids for wisdom teeth removal, this is an enormous problem. And for many of the millions of Americans who we're calling chronic pain patients who are on chronic opioids, many of them really started with an acute pain problem, were prescribed opioids aggressively, even in cases where they didn't need any opioids, and they became long-term chronic pain patients. So this is also why the CDC, in its guideline on opioid prescribing for chronic pain, put in a strong recommendation that for acute pain, that doctors should give only 3 days of medicine and rarely give more than 7 days. And with regard to dentists and wisdom teeth, the medical term for that is third molar extraction. For third molar extraction, routine third molar extraction, you don't have to give any opioids. In other countries, they're giving drugs like Advil instead of opioids, and they work more effectively. So many young people who become opioid addicted, even if they don't become addicted to that dentist prescription, they're basically getting their first taste of the drug from a doctor or a dentist. They're no longer afraid of it. If they like the effect, they're going to be much more likely to use and later become addicted. So that question is very much appreciated, and it is something that we're targeting. The other question, the HCAP surveys. So I do have some good news to report on the HCAP surveys. So you're absolutely correct. Hospitals were given a financial incentive for patients to walk out the door feeling that they got pain medicine every time they could have possibly have needed it. Doctors and hospital staff were encouraged to prescribe opioids aggressively, and in some cases even had their compensation linked to whether the patients rated them as treating their pain aggressively. And I can announce that the federal government, CMS, did change that policy, so there's now no extra money for hospitals for aggressive prescribing of pain medicines. The Joint Commission, however, has not really made any significant changes to the pain standards, the smiley faces and frowny faces we see every time we go into a hospital where we're asked over and over again about whether or not we have pain. That's something that still does need to be fixed.
Here.
Okay, before you do that, we're online for 4 minutes. We can stay here and answer questions, but we will no longer have our online audience to listen to those.
Good afternoon. I would just like to bring attention to something that I had never thought about until I had to experience it this year with my addicted son, who was using buprenorphine, naloxone, MAT. Was in an automobile accident, had to have surgery, and post-op pain relief. There are so many physicians that have absolutely no idea how to deal with this growing population of people who are on MAT or who are abusing opioids. And the mother bear had to come out in me, and I had to show the research and say, you're not understanding what buprenorphine does. You don't understand that we've got to displace that before any pain relief is going to happen. And I'm not talking minor injuries. I'm talking traumatic surgery. And then we also now have a growing population of addicts in recovery that are using Vivitrol. Has anyone thought, as physicians, what it means if those kids are in a major accident and walk into the hospital? How are you going to treat their pain? And it's just something I had never thought about until I had to experience it, and I would like to hear that maybe we are educating our physicians that they are going to encounter it if they haven't already.
Thank you for that question. And I come from a part of the country where I actually meet mother bears, so. And sometimes doctors need mother bears. I think you raise a critical point. We've talked about the lack of training for providers in pain management. I think equally important is the lack of training to understand addiction, what it is, what causes it, and very specifically, how do we take care of these other things that happen to people, whether they are struggling with addiction or are in treatment? Because having an addiction doesn't protect you from an accident. It doesn't protect you from diabetes. It doesn't protect you from much of anything. So we need to understand that management of the patient with addiction is part of taking care of any patient with multiple health issues. The part of it is actually removing stigma and having discussions. I think many of us who have been in clinical practice, our eyes have been opened because all we ever saw were the bad outcomes. And we didn't realize that there's a multitude of people who are in recovery, but they're oftentimes afraid to tell us that they are in recovery because of the stigma. We're trying something a little unusual in my state. We're actually creating, and we have the authority to actually waive civil liabilities related to this, but an advance directive that people can use to start the conversation, whether it's with their dentist, their doctor, whoever, to say, I am in recovery. I do not want to receive opioid medications. And it has been eye-opening for me. And let me just, again, just thank you to everyone in recovery who is here, who is educated, people like Howard and I and the other physicians, to help us begin to understand how much we don't really know. So it's a knowledge gap, but those conversations have to occur, because for some people, no amount at any time is right. There are exceptions, as you described, and we need to know more about how to manage those situations. Okay. I agree. Thank you.
I have a question for Dr. Kolodny regarding buprenorphine and medicated assisted treatment. And I know that the science says that 2/3 of people in methadone clinics are using other illicit drugs, and 1/3 of people in abstinence-based residential treatment are using other drugs. And there's also a lot of science that tells us that medicated assisted treatment, particularly methadone, has an extremely high death rate. It's associated with cognitive deficits that prevent people from figuring out how to get jobs and housing. It causes erectile dysfunction, very stigmatizing for young kids. They don't get jobs, etc. And so we keep looking at only overdose death without the side effects that are associated with medicated assisted treatment. So I'm wondering how to address that. And then the second question that I have is for Deputy Secretary Haft. As we have seen, opioids are deadly when taken as prescribed, and I'm wondering how, when our Director of Healthcare continually talks about programs to advertise opioid misuse, as opposed to opioids when taken as prescribed, that is misleading. And to have all of our funding regarding awareness go toward telling people not to misuse opioids and to talk to your doctor about opioid prescription is just a never-ending waste of money. And I'm wondering, as a Maryland advocate, what you suggest Maryland advocates do to change that, particularly in light of the fact that doctors opposed the limits on opioid prescribing that went along with the CDC guidelines last year. Thank you.
Thank you for the questions. With regard to treatment of opioid addiction with buprenorphine and with methadone, I did say that I think first-line treatment for opioid addiction is buprenorphine. I think that methadone also does play a very important role for people who are opioid addicted who may not do well on buprenorphine. We need better access to both buprenorphine and methadone. I will also say, though, that I think it's better if people can recover from any medical problem without having to be on medicines. Medicines do have side effects, and there are many people who have type 2 diabetes who, if they were able to really control their diet and exercise enough, they could get off of the insulin and they would only need the oral medicine. And if they did well enough, they might even be able to get off the oral medicine for their diabetes. But we would not say to people who have diabetes, you're only going to get your insulin for 6 months, and then you better have your diet under control. And if we did that with diabetes, imagine where we'd be in terms of blindness and renal failure, complications of diabetes. It would be a public health catastrophe. And that is where we are with opioid addiction right now, because we don't see that people who are opioid addicted have enough access to the treatments that are most effective. If you can recover from your opioid addiction without being on a medicine, that is terrific. And I think all of us, even people on medicines, would prefer to not have to take the medicines. But if we insist on it, we're going to lose many more people to this epidemic.
We've got to wrap this up.
Yeah. So I do need to kind of clarify one point that you raised, and that is deaths associated with methadone. That the vast majority of deaths associated with methadone are those that come from people who are prescribed methadone for pain, not for people who are using it for addiction treatment recovery. So I will tell you that all of the studies show that when people are on medications, they don't die. And I think that, and they recover. So I've heard this over and over again, and we're perpetuating, quite honestly, incorrect information as it relates to methadone for addiction treatment, and we need to stop doing that.
Thank you. We got to wrap up. One or two.
Science is not correct on their several
No.
studies. I agree with her.
Yeah, that's okay. Yes, next.
Alcoholic and an addict. My sobriety date is July 19th of 2011. Hey, everybody. Yeah. Thank you guys for what you're doing. This question is for Mr. Botticelli. And what frustrates me with the federal government right now is the politics of addiction. And, you know, we came here last year for funding of CARA, and it scares the heck out of me to have a chronic disease. This isn't acute, man. This is a chronic disease. And if they do repeal and replace, it just scares me, Mr. Botticelli. So what can we do as a group so that we don't get insurance pulled and we have to worry about previous conditions?
Sure. So thank you for your question. I have to say, what is somewhat distressing is, and I have to say, with President Obama, that this was largely a bipartisan effort. We worked hand in hand with Republicans on many of the things that we were able to get done. And whether that's 21st Century Cures or CARA, it was really a bipartisan effort. And I find it unfortunate that has changed. I will say a couple things. One is you need to make your voices known, particularly at the local level. And again, what was kind of somewhat distressing is many of the same people in both the House and the Senate who I know care about this issue, want to basically repeal Obamacare. That will have, and we saw the bills passed before, would have devastating consequences for people in terms of accessing addiction treatment. We also know that many of those people have hepatitis C, comorbid mental health conditions, other health conditions. So just replacing that with a slush fund for opioid treatment is not going to do the trick. So I think part of it is, and again, this is where advocacy comes into play, that legislators listen to people who vote for them. And it's really important that if they know that you have significant concerns with what changes to insurance coverage means for you, that they will listen. So you really need to make your voices known at both, particularly with your state and congressional delegations.
Okay. I'd like to intercede. We are offline. We are going to continue this conversation in the networking luncheon period of this program. We can continue to have these kinds of questions asked and answered. So we'll take one more question, and then we're going to move to the next room. Who has the microphone?
Hi, my name's Mary Beth, and I'm a registered nurse from Delaware. And I lost my son, Matt, to prescription drug overdose, along with methadone that he was also prescribed in a clinic and for pain. My question is, in Delaware, what I see in the MAT clinics, and I do agree that whatever works is a wonderful thing if it works properly. But what we have is, I have never as a nurse ever had to see patients line up on the street to get their insulin. Why do we do this to people that are in addiction? I don't understand. Okay, that's stigma. That just spreads the stigma. I also want to know is why are methadone clinics not user-friendly? In Delaware, there are very limited amount of hours. People miss work, they miss school, they miss a normal life because they have to go and get their dose. Also, in Delaware, there are some clinics that are now allowing benzos to be taken along with methadone. We all know that's a deadly combo. So my question is, I know methadone in my state is a big moneymaker for the state of Delaware. And I'm really so sick of addicts being treated like they are a commodity, like we are making money off their disease. I'd like to know, when are these methadone clinics going to be monitored, regulated? When are more doctors going to be educated in MAT treatment, that a patient can just go into a doctor's office like a normal person, not have to stand in line at 5 a.m. and be spit at and fingers pointed at people that are lined up. This is what happened to my son, and this is why people give up on MAT treatment, because they don't want to be called out. They don't want to have their lives, you know, for all the world to see. So when will we ever educate our doctors and have them just a plain old family doc, an addiction specialist, where you can make an appointment and you can go when it fits into your life?
Thank you. Yeah, we've got to move.
So I guess we just thank you for that question and your comment, and I think we agree with you. It's time to stop treating people with opioid addiction as if they're less than human. Thank you, everybody, for joining us.